Next speaker is Annette Kumlien, and Annette is the Chief Operating Officer at Diaverum. She is a member of the executive team of the group and is also on the board of directors, operational. So over to Annette.
Hello, this is Annette Kumlien. I hope you can hear me. Just to give you a short description of who I am, I work as a CEO today since 2014 in Diaverum, and I joined Diaverum in 2007 as the CFO. My prior career path was outside of the healthcare industry. It was actually in the process industry with specialty steels, specialty chemicals, and also consumer capital goods. I posted the presentation so you can follow along also to give you a little bit of a red thread through my speech. If you look at the agenda, it's a bit about setting the scene, what's going on in the healthcare, and I think Dr. Agarwal, as you also said, there is an issue when it comes to the tsunami of chronic patients coming in. It's a different profile. Looking at from the way that we are addressing, it's a bit what gets measured gets done, which is an old anthem, but also gets improved. And then also understanding the future from a patient point of view in order to deliver a better care, which is also affordable care from a national point of view. If you look at what's going on in the world today, there is a demand on the new system. If you look at most countries, they have set up their healthcare system based on acute illnesses because that's where we come from. So you get sick, you go into the hospital, you get cured, and you leave. But if you look at what's going on today with the lifestyle and the chronic diseases where patients have multiple diseases, it is not any longer going into the hospital, getting cured, and then you're done. It's actually so that you will return to your healthcare practitioners regularly and often, and different healthcare practitioners as well. And navigating as a chronic patient in a system which is set up for acute patients is not easy. And this creates a new demand on the system. And not only the system per se, but also on the healthcare professionals. When you look at changes, I mean, you have the incremental innovation and also giant leaps. Healthcare has never really been exposed to leap innovation as you have seen in other types of industries. And if you look back to when we went to the moon, as Neil Armstrong said, it's a small step for man, but a big step for mankind. There was huge activities going on to put the man on the moon. And it was a big change for us. If you look at an analogy into the healthcare industry, is that a lot of the things that we're doing now in the healthcare industry and that we need to address is a big leap for us. But maybe there's also some benchmarks and some best practices to be gained outside of this industry that has already been done in other settings. If you look at the industry that I am in, we're in the chronic kidney disease activity. We're dealing with renal patients that have lost their kidney functions. If you look at it today, there is around 7 billion people in the world. 10% of them, they have CKD. So we're talking about 700 million people, which is quite a big problem. There are 5 stages, and it's when you get into the 5th stage, CKD 5, that's when you lose your kidney function and you actually need a replacement therapy. The best option is obviously to get a transplant, but not all patients can handle this type of surgery, and there are not enough organs either. The second option is really to go for dialysis, and there are different methods. You can either go to an in-clinic hemodialysis, which means you go 3 times a week to a center and you get your blood cleaned. Or you could actually do home therapy, which means that that requires more or less more mobile and more agile patients to be able to do that. And also when you look at a renal patient, it's not only that they lost their kidney functions, there's a lot of services around it that needs to be addressed, like for instance, vascular access. And also you have transportation, patients need to travel. And also when you look at the renal patient per se, there are a lot of other comorbidities related to it. It is a growing cost. I'm not going to get into the exact numbers, but basically, if you look at it, CKD is about 10% of the population. When you look into the Medicare cost, talking about the US setting, where there's a lot of good data to watch, basically, the Medicare cost is about 30%. So you can see that the disproportional cost versus the number of people that are sick. And also, when you look at one of the causes for renal failure is actually diabetes. And you all know the tsunami when it comes to diabetic patients across the globe. Another impact also on, or why you would lose your renal function, is actually high blood pressure. And that is about 30% of the patients that come to us that have this problem. So with this type of numbers and you know what's going on in the lifestyle activities, you also know that this causes that tsunami of patients going forward. And then again, an acute setting system does not really work for the chronic patients. So how are we address this and how are we working? Well, basically, if you look at it, to get high quality care, there are 6 activities that we are focusing on. One of them is obviously how our operations look like. It's also looking at standard care, setting protocols. It's also about monitoring and making sure that we follow up and use this as a continuous improvement cycle. It's about incentives for quality. It's about also making sure to follow up with auditing programs to learn what gaps we have and where we can improve further. And then obviously also making sure that we have a competent and motivated staff. This picture just shows a bit of our different centers that we have around the world. Diaverum exists in 20 countries, and as you can understand, we need to adapt ourselves into the country-specific settings and also local regulations. And that makes our clinics look a little bit different. At the end of the day, it's about making sure that the patient gets treated in a way that fits him or her and address his or her need in those settings. The other thing is working with clear benchmarking and protocols, and making sure that those protocols are being underlined with scientific, with research that can improve them, and also making sure then that the collective knowledge that we have within our company actually is then being put into action through those type of protocols and standard way of working. This just shows a bit about how we work with what gets measured gets done. For the past 20 years or so, we actually monitored the key factors of making sure that the therapy that we do actually is effective. And as you can see also year on year, there is an improvement activity because of the learning curve that we are working on, and how we're addressing it with the different systems, the protocols, and also how people address in this continuous improvement process. That type of thing is, as I said, then also followed up with the auditing program, which is basically making sure that all our clinics are being followed up on a regular basis to make sure that they are following the settings that we have decided upon. We also work a lot with our staff to make sure that they're competent and motivated. We also work with our patients. So what we do is that we measure our patient and employee satisfaction on a regular basis. And with that, those comments and those intel that we get from these type of satisfaction research, we put up thoroughly action programs that we deliver on and move. And that's also where you can see that the improvement is coming into spec. So what about our patients though? Well, as I said, that our patients don't only have renal failure, they also have other illnesses, like they have diabetes, like they have issues with hypertension. So for us, it's very important to be able to make sure that we can actually work with the patients more holistically, and also make sure that in those countries where we're allowed to actually work with preventive care. Because at the end of the day, if you can prevent or delay a patient going into dialysis, that means a lot for quality of life and also from a health economics point of view. So if we look at challenges and solutions, it's a triangle activity. At the end of the day, it's about understanding our patients. We know that there is a tsunami because there is an older patient base. There's also more chronic diseases caused by the lifestyle that we are living in today. And when you look at it, making sure then also that we have the staff. And as you know, there is in most countries also a shortage of staff, and this is then we need to focus on how do we work with regulations, how do we work with also skill mix activities to understand how we can make sure that we can deliver the patient care that we are supposed to do. And then obviously at the end of the day, there is also a cost challenge going into the demographic side, where again, as Dr. Agva said also, it's about making sure that we can work with our patients from a holistic and integrated point of view and work a lot with preventive activities. So that's all from me. Thank you very much for your time, and I look forward to questions later on.
So thank you for giving again a very nice talk on the chronic kidney disease, which is again a very, very important part of our disease spectrum in our country also. So we'll now look at the some of the questions that have been posed. In fact, the first question that I can see is for me, that's by Shampa asking, Dr. Agarwal, what in the accreditation process leads to an improvement in quality, if indeed that is the case? Well, all I can say is that the main benefit of the accreditation is to move away from our individual ways of functioning to being process driven. And from individual to a teamwork culture is what we are trying to work out, that healthcare delivery, which was only between a doctor and a patient, has now become a multi-stakeholder delivery, and therefore all the people in the hospitals are equally important. So we are focusing on issues which were swept under the carpet, things like fire safety, or let's say hazardous material risk, so many things which the doctors were really not concentrating. We are now concentrating as a part of the accreditation. So there is some improvement. However, I would say that we are just scratching the surface as far as the quality is concerned, for two reasons. We have really not ventured into monitoring the clinical quality, which is the real thing in terms of how do we see that we do not make a delay in diagnosis, how do we really make sure that there are appropriate investigations that are done. So many things are still to be thought about, covered. I would say I heard something very nice recently in Canada, that mental health issues of the people who are working and of the institution was a part of the accreditation there. And the other thing is that if we do accreditation merely for the stamp of accreditation, then we are really not bringing about any quality improvement. So I think accreditation is a good way to start improving things. Next question by Shampa is to Cecilia. How long is the training process for the use of your products, and is that included in the price?
Well, our products are used in the same manner as other basic products. But again, what we do when we introduce our products into a new hospital is that we provide training for the staff, which can be in the form of a seminar, individual training of the trainers, because we do believe we also provide online training by way of videos and everything, because we think that the total package is important, so that you can not only introduce new products but also improve your processes and your way of working. And yes, it is included in the price.
So for Annette, do you set up centers within the hospitals too?
Yes, we have various settings.
Have you used it in Delhi? I'm sure that's to Cecilia.
Sorry, I didn't hear it. I was disconnected briefly.
I want to understand that some Bactiguard products were used in some Delhi hospitals.
Yes, RML and Sri Gangaram, and I'm actually visiting Max at the middle of this month. It's also used at Medanta, so yes, it is used in several Delhi hospitals.
So do we have data to show the impact of that use, is what the question is.
Yes, it's interesting that you should ask that question. We've just finalized the inclusion of patients in a study in India, including 1,000 patients at 5 different sites or 5 different cities across India with very favorable results. So In September, I will be happy to share that information. But we also have data and clinical evidence from several other markets that our use of our catheters will reduce infection rates by somewhere between 35 and 60-70%.
Okay. So we'll be very interested, of course, in I think getting some more data, and these hospitals should share their experience. What is the cost of the Bactiguard product? Is a question by Prabhavati Reddy.
Well, it depends on the product. So I don't know exactly the retail price in India off the top of my head, but it is more expensive than standard products. But so far, the prices which have been introduced in India have not met resistance because of the additional costs when you're not providing preventive action. So it has not been a problem so far.
Okay, so from where can someone get the idea about the cost, let us say, of these participants who have learned? I'm sure they may be, some of them may be eager to use. So whom should they contact and find out about the pricing situation?
They should contact our distributors, which is Neon Laboratories or Hospro for the west, north, and east of India, and Incarp for the south. But I can also put them in contact with our Director of Indian Operation, Manish Agarwal. There are contact details on the final slide of my presentation that I'd be happy for you to share with the audience.
Okay,
They can
so
also contact me so I can put them in contact with them. With the right people.
Okay. Then Shampa had, of course, another thing as a part of to Annette as to what is your biggest obstacle for training the staff or for the trained staff?
Was that a question for me as well?
Yeah, that's to Annette,
Okay.
actually. That because she was asked that, do you set up centers within the hospitals, and what is your biggest obstacle? Trained staff, is that your obstacle?
So yes, we do set up clinics inside of hospitals as well, and we have various ways of. We have actually different ways when it comes to clinics, depending on the country setting. Everything from management contracts, obviously, to our own clinics. So that's the basic modus operandi that we have. When it comes to training, this is coming back then again to, as I said, understanding what are key when it comes to treating a dialysis patients, making sure that you have protocols around it. And then we do have developed training programs for our staff. We have actually set up a Diaverum Academy where we have programs for our nurses, for our doctors, as well as for our clinic managers, and also for management positions, in order for the different categories to understand how to work. But yes, we do have training programs for our nurses and clinic staff.
Okay. Thank you so much. I